Good afternoon, everyone, and thank you very much for joining in. My name is Peng Wong, and I'm one of the consultant vascular surgeons based here at James Cook University Hospital. I'm also a regional surgical advisor for the Northeast region. And we're very, very pleased today to be able to host this session for all the medical students. And we'd like to thank the college for facilitating this session, and also especially Mike Silver, the director of the Regional Surgical Network, and also Mr. Barney Green, and the whole Regional Surgical advisors network for holding this session whilst the COVID pandemic is ongoing. So I'd like to introduce our speaker today. We're very, very honored to have Mr. Barney Green. He's a very, very experienced speaker, very, very entertaining, and I'm sure we'll learn a lot from him. Barney is also a deputy director of the Regional Surgical Advisor Network. He's the clinical lead for safer surgery here at James Cook University Hospital. He's also a convener for the Advanced Cadaveric Vascular Skills course. And the topic he's going to talk about is acute limb ischemia. It is a very important topic because at some point in our career, we will encounter patients with acute limb ischemia. He will help us, show us the final points on how we manage them. So without much ado, I'm going to introduce Mr. Barnabas Green. Before I pass the mic to him, I'd like to remind the attendees that we can all use the Q&A icon at the bottom, and we will try to answer your questions, and there will be a poll at the end. So I'm very honored, Mr. Green.
Thank you, Peng. That's a very kind introduction, and probably not as deserved as you said. But anyway, welcome everybody. This is the third week of webinars, and what I want to try and bring to you today is a real life experience of dealing with acute limb ischemia. So we'll move on very quickly. If I can get my mouse to work, here we are. There's four real key points that I want us to go through. I'd like us to understand what acute limb ischemia is, how we might spot it in real life amongst all the busyness of the ward, what's the best way to treat it or investigate it or manage it, and then a little bit really on what's the best thing for the patient when all things are considered. So the first thing with everything is to put it in context. Acute limb ischemia happens in a particular context, and it's quite important that we understand exactly what that is. Now, peripheral arterial disease, I'm sure you will know, is a major cause of morbidity and mortality worldwide. And it's estimated somewhere between 12 and 15% of deaths per year in Europe are attributable to peripheral arterial disease. Now, of course, that's the whole spectrum of arterial disease, not just acute limb ischemia. So remember that. But if you start to look at how often we see the acutely ischemic limb, then we reckon somewhere between 1.5 per 10,000 people per year. So in our catchment area here in Middlesbrough, we would expect to see somewhere around about 240 acutely ischemic limbs every year. So that's patients who've never had arterial disease before, who've had an embolus, and patients who have underlying arterial disease. So it is a big problem. It's also a big problem because the complications, even despite revascularization and limb-saving surgery, can be quite high. 30-day mortality rates and amputation rates are startlingly high when you think, well, this is a surgery that we're doing to save somebody's limb. And part of that is effectively related to the people who come in with arterial disease have got a global vascular disease. Their incidence of heart attack is much higher. You are taking somebody who may have deranged acid-base balance, reperfusing that limb, getting blood back into those tissues and having a lot of the washout from that as well. So stroke, deterioration in your renal function, et cetera, et cetera. So that's really the context in which we see the problem that we have. So what is it? Well, the acutely ischemic limb is simply when there has been a sudden decrease in limb perfusion that threatens the viability of that limb. You'll all remember this, of course, it's very basic physiology. You breathe the oxygen in, it gets itself into the blood, and off it is delivered into the tissues. So the resulting ischemia from the loss of blood supply and nutrition to metabolically active tissues, for example, skin, muscle, and nerve, is affected all of a sudden, and that will manifest principally as pain, but then with time, a detriment to that tissue. When is acute acute? Well, you know, people talk about 2 weeks being an important time frame. I think in your mind's eye or in my mind's eye, we might be saying, well, this acutely ischemic limb came in overnight last night. But it's, you know, somebody could embolize down their leg, block off a small vessel, and have symptoms that have taken place over the last couple of days. So the spectrum with which somebody may present to hospital might be slightly different to how they present to their general practitioner, but be mindful that they may still come in having only had a sudden deterioration, albeit mild, in their walking distance, all the way through to a paralyzed and mottled limb, which is the very severe end of the spectrum. The presentation, of course, is entirely related to the level of the blockage. If you block a large vessel, all the tissue distal to that is in trouble. If you block a small distal vessel, you might not have so much of an issue. And I wondered if you could do something. Nobody can see you at the other end of your webcam. You can all see me. But what you might be able to do is do some exercise. So if you were to get down from your chair now and do a couple of little squats, let's try that. There we go, up and down, up and down. That's some exercise. Now, what I want you to do is block one nostril so that you're breathing less, okay? And go up and down, and see how you feel. And then block both nostrils. Well, you kind of get the idea, don't you? That the more vessel that is occluded relates to how severe the presentation of that person might actually be. I hope you haven't passed out by now, but if you have, take a moment to recover yourself. So critical limb ischemia is another phrase that we hear and sometimes get the two mixed up. Oh, is this critical? Well, yes, the situation is critical, but it's not critical limb ischemia as we would know traditionally, because that is a scenario where you have ischemic rest pain for greater than 2 weeks, which hasn't been relieved with analgesia and/or there's evidence of tissue loss. This is actually a patient of mine, reproduced with his permission, who had chronic arterial disease, who had a revascularization process, but sometime later down the line had another event. But critical limb ischemia is very different because you tend not to lose your leg all of a sudden. You might lose it in installments, and that's simply because of the collaterals that are present. We all remember this equation, don't we? C6H12O6 plus 6O2, and the plus at the very end. Can anybody remember how much ATP you might produce? I'll put you out of your misery. It's 38. The anaerobic side of things, however, is a lot less. So those patients with critical limb ischemia who are respiring effectively anaerobically produce a lot less energy. They can control those metabolically active tissues a lot less effectively, and that's why you start to run into a problem. Again, the critical limb ischemic patient is going to present on a whole spectrum all the way through. And if you look at the bottom of the screen there, my kind of Mickey Mouse pictogram shows a progressively blocked vessel, which progressively reduces the amount of oxygenation of the tissues and presents all the way through to critical limb ischemia. But this is acute limb ischemia. This is where there's been a sudden decrease. So why might you get a sudden decrease in blood supply? Well, we all know about embolization. And embolus comes from the Greek word meaning interposition. So something gets in between the blood flow and the receiving tissue. And the cause of embolization, as you well know, could be arrhythmias. It could be an aneurysm that's shed some thrombus out of its sac. It could be an atheromatous plaque that has suddenly ruptured and shed its thrombus load down a vessel. We also have another phrase called thrombosis in situ. So imagine having a pristine artery, that could be subject to embolization. But if you've got the craggy atherosclerotic vessel with plaque rupture, it doesn't have to embolize, it could simply occlude in that one place, and there you go, you've got your thrombosis in situ. Trauma to that vessel, so simple vessel disruption, actually detaching the two ends of that vessel, there is therefore no perfusion. An extrinsic compression of that, so compartment syndrome, post-traumatic compartment syndrome is something to be aware of. As more and more patients have surgical revascularization, then you have to think, what about the graft? What about the stent that they had put in? Has that now thrombosed off? And then there are some other less common, but you must be mindful of all of these conditions that can present with an acutely ischemic limb. I think I've seen one patient, a young 13-year-old boy who had an atrial myxoma, who had been showering emboli down his legs progressively. Now, he didn't present acutely, he presented on that spectrum of critical limb ischemia, but it does happen. And of course, the cleverer we are getting in medical interventions these days, the more we are at risk of causing iatrogenic injuries. I think one of the other things to remind you is that you can get a paradoxical embolus. So you can have an acutely ischemic limb from an arterial occlusion with an underlying or a precursive deep venous thrombus. Now you have to think about the circuit and how that's bypassed the lungs, and that's maybe a question for later that you can answer. Arteries also dissect, and that can cause a flap, stop the blood flow. But at the end of the day, when you're trying to understand your etiology, then history is absolutely everything. And you must pay attention to that history because it will guide you trying to figure out how caused. So how would we spot it? Well, we do know that the symptoms develop over a period of time. It can be very acute or it can take quite a bit of time. But of course, they range all the way through I'll go back a page, from simply a deterioration in their walking distance all the way through to the acutely gangrenous leg, the infarcted leg with spots of gangrene. So the classical mnemonic that we've all learnt is, I'd love to see a show of hands now, because you're all going to go, it's the 6 Ps. So I've tried to put these in what I think is a relevant order for presentation, because as soon as you lose that blood supply, it becomes very painful. And it will be pulseless, and of course, it will be pale. Now, most people say, my foot is painful and it went white. They won't volunteer that it's pulseless. But these 3 things must happen together. As that ischemia progresses, you then get this other thing, poikilothermia. I'm sure you were saying, no, that's wrong. It should be perishingly cold. But I'm going to argue that actually, no, it's poikilothermic. And what that means is, if you're a reptile, you are a poikilotherm, which means you take on the temperature of your surrounding environment. So if the blood flow has stopped going into that leg, it then cools to room temperature. It's not actually freezing cold, but it feels cold, if you get my drift. Following that, as the nerves start to suffer, you become paresthetic and ultimately paralyzed. And if a patient has presented with a paralyzed limb, you know that significant damage has already taken place. So what about examination findings? Well, there's always general examination findings and then limb-specific findings that you must pay attention to. The basics, heart rate and rhythm. What about some murmurs or bruits, something that might give away an etiology? Has the patient had an operation before? Is there a scar to look at? What about a pulsatile mass? So where do we go to feel those? Somewhere in the epigastrium, that's definitely one, but don't forget the popliteal artery aneurysm. Go up behind the knee, but don't forget you should feel the distal thigh. Just as the superficial femoral artery comes down and then starts to turn towards the popliteal fossa, the aneurysms are usually much higher up than that. So have a good examination of that leg. And always examine the other leg. If the left leg is acutely ischemic and the right leg has palpable pulses, that's telling you something about the underlying artery and what you might be able to do to save that leg. If there are absent pulses on the contralateral limb, again, that's telling you something about they probably got a degree of peripheral arterial occlusive disease. But a saddle embolus is going to block both sides, and they will both be acutely ischemic. So, have a look at both legs. Don't just look at the painful one. What about the specific findings themselves? Well, we would think that as soon as it's ischemic, it becomes pale, and that's true. It's marble white to start. Someone's just turned my lights off. Thank you. I do apologize. That's the problem with working in a busy hospital where we're trying to save energy. So the limb itself would be marble white to start with because there is no blood going into it. You might see what's called venous guttering. So whereas you look at your veins and they're standing up, there will be a little gutter where that vein should be. And eventually you start to get some mottling appearing. And this mottling is actually, once the vasospasm initially has settled, in the skin it relaxes, but you've got deoxygenated blood now coming back out of the limb. That will blanch for a particular period of time until it becomes fixed staining. And then, you're really in trouble. What about the compartments? Are they tender? Are they sore? Is the ankle joint or the wrist joint, is it fixed? Can you move it? All of these will give you an indication of how advanced that disease is. And then we use this word woody. The leg is really woody. If you're finding that, you know that you have got a really significant problem. So Mr. Rutherford is responsible for all sorts of classifications, but this is a good one to look at. And you can maybe come back and look at this in more time later on. But effectively, there are 4 stages to pay attention to. Number 1, the limb is viable. Number 2A and 2B, I'm going to clump those together and say this is a limb that is threatened, and depending on where they've come in their timing, you may or may not have time. And then stage 3, or actually the 4th stage there is irreversible damage. That limb is beyond salvage. So when we talked at the very beginning of saying, well, what's in the patient's best interests, we'll come back and think about that very shortly. But your examination findings will be related to that stage. So if there's still sensation, if there is still movement, and if you can actually still hear a Doppler signal on handheld Doppler, then you're most likely dealing with a viable limb and you've got a bit more time. And that spectrum presents all the way through to the completely irreversible leg. So how do I treat it? Well, for you working on the wards, I'm hoping that you will be given some instruction from your registrars and or your consultants. But if you were to find yourself in that position of being the first responder, there are questions you have to ask. Number 1, how much time do I have? Time is tissue. We say that time and time again. The more you delay, the worse the outcome for that patient could be. So how much time do I have? What can I do in the meantime to stop this getting worse? How can I alleviate that poor patient's symptoms? Because this is not pleasant pain. And finally, how can I prove my diagnosis so that I can make my plan going forwards? The last thing really is the most important thing, and that is who needs to be involved. Because if you're on your own and you don't feel like you've got any help, you might be in big trouble. But there's always a phone, there's always somebody. And if you don't know who to get involved, you must phone your consultant. We love being woken up in the middle of the night. It's really important to do that. Do the basics. Everybody knows this. ABC, resuscitate. IV access, get a catheter in, because it's all about fluid balance, and do an ECG. Unfortunately, time and time again, we forget to do these very basics. So I want to implore, please make sure we do the very basics. Do a Cardex, get the analgesia, etc., etc. Draw some bloods. Which bloods should I take? Well, the basic ones, the ones that everybody knows about. But think a little bit laterally. If you want to know what stage they might be, an acid-base assessment might be quite helpful. And if you want to know if your treatment has made any difference to that limb, serial creatinine kinase blood tests will also be useful. Before you load them up with anticoagulation though, don't forget, draw some blood for a coagulation screen, because once you've started them on treatment, then it's very difficult to assess whether they've got an underlying coagulopathy. The immediate treatment is always going to be intravenous heparin unless there is a contraindication, because this enables your body to lyse naturally the thrombus that's starting to form, and it inhibits clot propagation on that clot already. How much do we give? 70 units per kilogram, up to a maximum dose of 5,000 units. Don't forget the 80-year-old little old lady from a nursing home may only weigh 40 kilos. So you've got to do the mathematics and then set up your infusion as per local protocol. Get some robust anesthesia and think about simple measures to improve the perfusion and the oxygenation of that limb. Oxygen, we don't do it enough. Correct hypotension. Pressure relief, well, I'm hoping they're not in the line for hours and hours and hours, but just be mindful of the heels and the sacrum and various pressure points. Dependency. You'll always find us vascular surgeons going around the ward saying, get your legs up, get your legs up. But these are for critical ischemic patients who have got used to dependency at home and now they've got a terribly edematous leg. But in the very short term, whilst you're trying to plan, actually a bit of dependency might give them some symptomatic relief. Medical treatment really boils down to thinking about what coexisting diseases they have and make sure you take care of those. Because sometimes, or more often than not, this process happens coexisting with another acute deterioration, whether it be a deterioration in their renal function because they're dehydrated, because they've had a diarrheal illness or a diabetic ketoacidosis. So just think about all of these. Treat the implicated medical conditions. So uncontrolled heart failure, uncontrolled fibrillation. But what about dissection? You know, if it's an aortic dissection, well, that's going to need very close monitoring on a high dependency unit with blood pressure control, et cetera, et cetera. So those things must be taken care of. But ultimately, we're surgeons and we want to think about the surgical treatment. So what options do we have? Catheter embolectomy, either under local anesthetic or general anesthetic, seems to be the mainstay of what we can offer, and that's a very good treatment to do. Immediate revascularization to save the limb is a priority, bearing in mind where they present on that Rutherford stage. Now, sometimes that surgery might be a simple femoral cut down, but sometimes it might include multi-site surgery, endarterectomy, bypassing, and don't forget the fasciotomies. On-table thrombolysis is also helpful, but if you've just done a fasciotomy, I can tell you, you are going to regret that because it stops all the clotting from happening and it tends to be a bit of a soppy mess. But if it saves a leg and you must do it, then that's really helpful. Imaging of the vessels, again, is a key part. You need to know what is what. You need a clear roadmap of your arteries. You need to know where the thrombuses come from, and that means you can then make a decent plan going forwards. Duplex is very good if you've got it to know where the blockage is, but it doesn't show you your distal vessels very well. CT angiogram does. On-table angiogram, if you've got the skills and the setup, is also another good way of dealing with that. Okay. But I would say imaging shouldn't delay your treatment. Impress upon radiology the importance of time. When I say imaging shouldn't delay treatment, you have to be pretty brave going to theatre without preoperative imaging. So really, the key here is to make sure that the radiologists do the scan that you need and not to take, well, we've got a 3-hour wait for an excuse. Now, this image is very busy. And again, I want you to go back and look at this later. But this is a very good algorithm from the Transatlantic Inter-Society Consensus, number 2, on how to regard the acute ischemic limb. And again, if you look carefully, you'll see that it talks about these words: viable, threatened, and then irreversible. And as you work your way through this algorithm, you see at the start with heparin, do your examination, so don't delay your heparin to try and make your diagnosis. If it's an acutely ischemic limb, get on with the treatment and then do everything else afterwards. And it will work you all the way through surgery, thrombolysis. I don't want to get into thrombolysis right now, that's quite high level thinking, but some people are candidates for catheter-directed thrombolysis and some not. We can discuss that in the Q&A later on. But that's a very busy slide, so I tried to simplify it into this. When they present, you need to give them intravenous heparin. You then need to think about imaging and treatment according to their level of severity. Is the limb viable? Is it threatened? Or is it non-viable? Because these will say how much time you have. In that viable limb, you should be saying, got plenty of time to get a scan. I'll give them some novel anticoagulant therapy and I'll send them home and treat them as an outpatient. I've got time to take some pictures. Whereas with the threatened limb, you may have time, and again, you might not have. And I think that's where careful representation of the clinical findings to your superiors are really, really important, and get an early senior review. Now, what about the non-viable leg? Well, you don't actually need any imaging. You don't have much time because the time has already gone. So maybe actually you have a lot of time, unless, of course, that leg is making that person really sick. And then you have to make a very difficult decision to say, well, is it palliation or is it amputation? Again, that's not a decision we're expecting you to make on your own. This is something that we make collectively as a team. But I want you to try and understand a little bit of our mindset. If we come on and we say, I'm afraid for this person, we can't do an amputation. And you'll say, but last week we did the same kind of a guy and we gave them an amputation and all was well. So these things are very difficult to decide. And you certainly need some experience in that. Post-operative care, that's the most important thing. Read the operation note. How many times we've come back to the ward and someone said, what's your plan? And we said, well, did you not read the op note? And they go, oh, I didn't know there was a plan on the op note. It's like, there is a plan on the op note. Regular distal observations are fundamentally important. You've just revascularized the limb. You've done everything that you can to save it. There is still a chance it could rethrombose. So my personal practice is to put an indelible marker on the foot where the pulses are, and I will write palpable, and that means you can feel them, or I will write Doppler signal, which means you cannot palpate them, but you can hear them. And that way, the nursing staff on the ward will know exactly what to expect when they come back, and any change from that clearly needs highlighting. You're going to get some reperfusion injury, reperfusion pain, that sometimes is welcome because it's different to what they had before, but you do need to take care of it. Post-operative bloods are fairly standard, but is that creatinine kinase that you took before getting better? Is the kidney function improving? Have you saved them from an acute kidney injury as well? So then we think about long-term anticoagulation. Where do we go with that? Quite often we would say, well, we know what the cause was. It was atrial fibrillation. They're now in AF and we've done their bleed scores and their thrombosis scores. Actually, they need formal anticoagulation. And then you're directed by that medical decision. But occasionally we'd say, well, we're going to try and rationalize this in the context of your comorbidities, whatever that might be, your falls risk, et cetera, et cetera. So we might adopt a slightly shorter duration of anticoagulation to get them over the hump of their event and then review that in the outpatient clinic. Rehabilitation is very important. You might have done fasciotomies, you might have corrected the fasciotomies, but that's still going to take some rehabilitation. For the person who's had the amputation, of course, rehabilitation is a completely different kettle of fish. And of course, on the ward, you might be saying, well, there may still be some more surgery that is needed. So don't start the warfarin just yet, or whatever the decision might be. And then when they finally do go home, what about your outpatient review? If you've had to do something fairly heroic and extensive to revascularize that limb, for example, a bypass graft, what's your plan for following that up? And as new doctors on the ward, we will be encouraging you to make sure that that plan is clearly documented and any follow-up scans are arranged before they go. At least that's our local practice here. We all know about risk factor management. It would be a shame to save somebody's limb and not deal with all the things that we know cause arterial disease in the first place. The standard antiplatelet and statin therapy at the moment, of course, is clopidogrel and atorvastatin. So you should be checking their cardexes and their medicines before they go home to make sure those are in place if you haven't made a decision to put them on formal anticoagulation. So just very briefly then, before we finish, what's best for the patient? Now this can be very difficult because you don't always really know what's going to come your way until it comes your way. So having a stock answer for, well, I would treat this with X, Y, or Z is not always right. So the patient's therapeutic strategy is always going to depend on a multitude of factors. The type of occlusion, where they had it. Was it an aortic occlusion? Was it a distal femoral or tibial vessel occlusion? What about the location? What about the type of conduit that blocked off? What about the class or the stage that they presented in? What about the duration of ischemia that they had and the comorbidities? And will they get through your crazy idea of how to revascularize the limb? What about all the risks related to that therapy? So you must be mindful of all of these when trying to make your decision. And so sometimes when the boss says, treat that with IV heparin overnight, and the next time they say, why didn't you call me? That guy needed surgery straight away. It can seem very confusing. But if we pay attention to everything in the background and all of these factors here, you can often find an easier way to muddle your way through the difficult decision making. At the end of the day, when it's all said and done, communication is incredibly important. So I would say that greater value lies not in how you wield your knife, but in how you counsel its use in the first instance. Patients and relatives will really understand why you've done what you've done and the things that have been done to them much better if you're clear in your communication. And being a clear communicator, I would argue, is a greater skill to master in your journey of surgery than the actual surgery itself. So I'm going to end there, but I'm going to end with a case scenario, and we're going to open a poll and we're going to see what you think would be the best way to treat this. So within this, what I want to remind you is that we've thought about what acute limb ischemia is. We've thought what the basic management might be, how you might revascularize a limb based on patient factors. Okay, so bearing that in mind, this is the case scenario. A 61-year-old male who's a keen golfer, they always seem to be that, presents with an acute onset of right foot pain, numbness, and partial loss of motor function. So from that story, you're already starting to think, I think I know where on the spectrum this guy is, but what you don't yet know is anything about his past history. So if you're lying at home in bed and you're taking the call, you'll be thinking, plan A for this guy. However, plan may change. 4 months ago, he had an endovascular treatment for a severely disabling claudication with a right external iliac artery angioplasty, stretching it open with a balloon. This was complicated by a rupture of the artery and subsequently was treated with what we call a bailout covered stent. So that was to stop him from bleeding to death. On examination, the pulses in the right leg are impalpable, the foot is cool, and it is mottled. You managed to get a CT scan, and this shows an occluded stent with thrombus in the common femoral, the superficial femoral, and the proximal profunda femoral artery. The tibial vessels you can't really see. They're not opacified, but there is some diffuse calcification within them. So I'm going to ask Ryan if he'll just quickly open the poll and get your answers on how this case should be best managed. Then I'm going to hand over to Mr. Wong, who's going to coordinate the question time.
Thank you very much, Barney, for the excellent presentation and very, very enlightening. So just very quick poll for the next few seconds. How should this case be managed? A 61-year-old gentleman on a background of previous endovascular intervention who's now appeared to have developed acute limb ischemia. Anticoagulation and observe, attempt iliac and femoral thrombectomy, anticoagulate and perform a fem-fem crossover bypass, plus femoral embolectomy and fasciotomy, anticoagulation inflow procedure, distal bypass, or amputation. Okay. Well, we'll have the results of the poll shortly. So, Barney, some of a few questions. We've had lots of questions today, very, very engaging participants. So we've now got the result of the poll, and majority of them were anticoagulate, consider performing femoral crossover bypass, femoral embolectomy, and fasciotomy. What do you think?
Oh, well, I think you're all secret vascular surgeons, because that's probably what I would do in this case. And I'll tell you why. Simply because you've got to deal with what's in front of you. You've got somebody who you know had previous history of arterial disease, but you know that their iliac angioplasty resolved their scenario so they could go back to being a keen golfer. And that was with the presence of tibial vessel disease. But unfortunately, the stent is thrombosed. I wouldn't necessarily try and thrombectomize that, because you might end up pulling that covered stent out and end up in a whole heap of trouble. I'm very quick at doing a fem-fem crossover, get the thrombus out of the superficial femoral, the profundo, and the common femoral, crossover, and then leave it at that. Now, if the time was beyond 6 hours, or if it was on the cusp and I thought, well, I think I should do a fasciotomy, I would do a fasciotomy as well. So I think I would answer that in exactly the way that most people answer that.
Okay, that's marvelous. Now we've got lots of questions, and for the sake of time, I'm here to skip through quite a few of them. So some questions were, how would arrhythmia and aneurysm cause embolization?
Okay, well, I mean, this is a very simple answer to that one. Do you want to answer that one, Peng? Or do you want me to answer that?
Yeah, so I think with any arrhythmia, if you imagine the left atrium, for example, when it contracts in an asynchronous fashion, there's always a risk of thrombus formation. And similarly with aneurysm, there is often thrombus around the aneurysm. So this aneurysm thrombus could also embolize. Then the question is, can acute DVT also sometimes present as or mimic acute limb ischemia? Yeah, and I think it can. And the reason it does that is because of the increased compartment pressure, reducing the venous return, making the whole leg looking very ischemic. And that's probably why sometimes when we revascularize a limb, the limb may also become ischemic later on due to compartment pressure. Yeah. Another question, Barney, is the difference between acute limb ischemia and acute on chronic limb ischemia. How could we differentiate the two?
Okay, so that's an excellent question, and I think that's probably a vast majority of our patients would be acute on chronic limb ischemia. A number of things to bear in mind. History is fundamentally important. So you'll get an indication that they had chronic ischemia beforehand, peripheral arterial occlusive disease, based on questions like, did you have claudication, and so on and so forth. Now, those patients would present with an acutely ischemic limb because some small remnant of their blood supply has thrombosed off. The challenge really is going forwards. Native arteries that have an embolus in them, you can pull that out and happy days, you crack on. But something that's got a lot of craggy atherosclerotic disease, your revascularization strategy is going to often be far more complex. Now, thankfully, with a lot of these people, they are used to running on a bare minimum. So you've got a lot more time to try and figure out what to do. But I would always advocate anticoagulation, get decent imaging, make sure that patient's safe enough to make a forward plan and then go from there. Unfortunately, some people just don't afford us that time. And the only solution that we would have is an amputation. Peng.
Okay. Probably the last question now. How would you differentiate between a viable limb, a threatened limb, and a non-viable limb? So perhaps for me, I can say that after the 6 Ps that we talk about, power and sensation are two most important things for me. If a power is present, sensation is present, the limb is safe. If a power is reduced, sensation is reduced, the limb is threatened. If the power is absent, sensation is absent, the limb is potentially non-viable. So any important take-home message for us, Barney? I know you've done a brilliant presentation, and you should, cover a very, very broad topic within a short period of time. Any take-home message for the students?
Time is tissue. So, make sure you see that person quickly. Make sure you're vigilant. If the nurses say to you, look, this guy had a bypass graft yesterday and his foot is now white, go and see them straight away. That's an acutely thrombosed graft until proven otherwise. So time is tissue, and the amount of time it takes to treat them could be the difference between keeping your leg and losing a leg. Don't forget heparin. That's probably the key treatment to start with, and correct all of their medical comorbidities that are important. You can't, if you're going to write pulses and Dopplers, you should be saying, I can feel a pulse or palpate a pulse, and I can hear a Doppler. Okay, so you don't detect a pulse with Doppler. You're mixing your language up. So palpable pulses, audible Doppler. Call for help early. I think that's really it. Recognize the problem, deal with it quickly, and get your seniors involved.
Thank you very much, Barney.